Hello, and welcome to Triage, timely conversations for healthcare professionals, a podcast created and produced by K&L Gates. This episode of Triage is recorded in collaboration with Working Wise, a K&L Gates podcast that provides labor and employment updates and compliance tips to lawyers and HR professionals. We hope you enjoy this episode.
Hello, I'm Sarah Carlins, a member of the K&L Gates healthcare practice in the Pittsburgh office. I'm here today with my partner, Jackie Hoffman, who is in our healthcare practice in the Dallas office. And today we have the opportunity to speak with our colleague, Craig Leen, who's a partner in the Labor, Employment, and Workplace Safety Group in our Washington, D.C. office. Prior to joining K&L Gates, Craig served as the director of the Office of Federal Contract Compliance Programs at the Department of Labor. We have the chance to speak with him today about that agency's regulation and enforcement in the healthcare space, which might impact our healthcare clients. So with that, Craig, welcome, and we're so happy to have you here today.
Thank you, Sarah. Thank you, Jackie. It's such a pleasure to be here today. I joined K&L Gates right at the end of April. It would have been several months since I was the OFCCP director. I was so excited to join such an outstanding firm, and I'm excited to be here today to talk about OFCCP, something I know a lot about, and an agency that was part of my life, for several years as the director. And I hope that I'll be able to add a lot of helpful information today and some insights that will be helpful to contractors, stakeholders, to those who want to comply with OFCCP requirements. Looking forward to this very much.
Great. Thank you, Craig. And I think the first question I would ask is just very basically, what is the OFCCP? Because there may be listeners who aren't really familiar with the agency itself.
You're right. If you did a general survey of the American public, most people have not heard of OFCCP. It's basically the EEOC for federal contractors. It's called the Office of Federal Contract Compliance Programs. It's part of the U.S. Department of Labor. It regulates 25,000 federal contractors across the United States. Those 25,000 contractors have about 120,000 establishments, and an establishment's an office or a factory, headquarters. So 120,000 different places across this country are regulated by OFCCP. They basically have authority for about a quarter, 20% to 25% of the American workforce by different estimates. So it's an agency that has a lot of influence, has a lot of authority, but not a lot of people have heard about it. One other thing that's interesting about it is the agency, to those who know about the agency, its primary authority that sort of founded it and that it enforces is Executive Order 11246. That authority is an executive order, so it was actually done by President Johnson, and several other presidents have amended it over time. And then there's two other authorities the agency enforces. Those are Section 503 of the Rehabilitation Act, which is something like the ADA, the Americans with Disabilities Act for federal contractors. And then also VEVRA, which is a Veterans Civil Rights Protection Statute. And among those three authorities, the agency basically requires affirmative action and prohibits discrimination based on race, color, sex, sexual orientation, gender identity, national origin, religion, disability status, veteran status, and it also enforces pay transparency. It touches on all aspects of American life, and it's a powerful agency. It actually has a lot of authority for not being well known.
So, Craig, is the OFCCP active in the healthcare industry in particular?
Yes, it's very active, and that's why I'm very happy to be on this podcast today, because not only is it active in the healthcare industry, it's going to be expanding its activities likely in the healthcare industry over the course of the Biden administration. That's a prediction I would make, just based on my experience there during the Trump administration, and also just the fact that it's an area where we'll probably talk about this later, but it's an area where there's a lot of compliance issues. And so the agency is really interested in healthcare. Healthcare is a huge part of the economy. And I told you before, OFCCP touches about a quarter of the workforce, and healthcare is a big part of that. So I know the agency is very interested in doing more in the healthcare space. The agency has had numerous recent reviews and conciliation agreements, which you can see on the agency's website, involving healthcare entities and university hospitals. In addition to that, the agency is concerned by significant pay gaps in the healthcare profession, and I hope we get to talk about that a little bit. And the agency has also addressed, during the Trump administration, and even going back into the Obama administration, there was a lot of debate and even controversy to some extent over the scope of OFCCP's jurisdiction over healthcare entities. recently, when I was director, the agency published an actual regulation on that called the TRICARE rulemaking, which touched on its jurisdiction in the healthcare field. And so I'll just tell you, because this has been made much clearer now by this regulation, the agency does not have jurisdiction or does not exercise jurisdiction over TRICARE, Medicaid, and Medicare Parts A and B, but the agency does exercise jurisdiction over FEHBP, which is basically the federal health insurance plan, and VAHBP, which is the Veteran Affairs Health Benefit Providers plan, and Medicare Part C and D. That's still debated whether the agency has jurisdiction there. So, and most hospitals in some way are federal contractors or subcontractors, and most university hospitals are as well. Indeed, even hospitals that for some reason did not take FEHBP or VAHBP or Medicare's Part C and D, they also might be contractors because they might participate in vaccine trials or contract with the NIH in some way. So there's many different ways that you can become a federal contractor or subcontractor. And so the main point, though, that I wanted to make was if you're a healthcare entity, there's a really good chance that you're a federal contractor one way or the other. Even if you accept TRICARE, for example, where you wouldn't be a contractor, if you also take FEHBP, then you are a contractor. So at least when I was at the agency, the analysis we did was that most healthcare entities are federal contractors. And I know that the agency is very keen on doing more in the healthcare space.
So, Craig, this is Jackie. Thank you very much for your explanation and your education about the agency for us. With that being said, and your emphasis on the agency's interest in the healthcare industry and the fact that a lot of providers, hospitals and hospital systems might be falling into the purview of the agency without really historically being tuned into that application, what are the obligations that clients like ours, healthcare entities and hospitals, that they need to be aware of for purposes of being sensitive to enforcement?
So that's a great question. If you're a federal contractor, and as I mentioned, most healthcare entities are likely to be federal contractors or subcontractors, and this applies to both contractors and subcontractors. There's two primary areas where you have compliance requirements. One is in the affirmative action area, which the agency also refers to as affirmative obligation, and then in the non-discrimination area, which the agency refers to as the non-discrimination obligations. So in terms of the affirmative obligations, you would have the responsibility, if you're a federal contractor or subcontractor, at your hospital and every establishment that you may have, if you have clinics or offices or things like that, you would need to have an affirmative action plan in place, assuming you meet the jurisdictional requirements. And, there's a number of different jurisdictional requirements, but the basic one for the executive order 11246 is if you have federal contracts or you're getting, patients through FEHBP, and that amounts to more than $10,000 in a year, then you're a federal contractor. And if it's more than $50,000 and you have more than 50 employees, you have an affirmative action obligation. And the thresholds are a little bit different for Section 503 and VEVRA, but they're similar, particularly for 503. They're very similar to the executive order ones. For VEVRA, the threshold is $150,000. So as you can see, most hospitals healthcare is expensive. You're going to be meeting those obligations very easily. So that's why I can say with a pretty high degree of confidence, if you're accepting FEHBP, if you're accepting government contracts or subcontracts, you're extremely likely to have compliance obligations as to all the protected classes I mentioned earlier. So that means that for your doctors, your nurses, your technicians, your administratives, your administrative personnel, your professional personnel like your lawyers or engineers or anyone that may work in your hospital facility, your executive staff, your service staff, people who work in the cafeteria, people who clean the hospital, all of those employees would have to be included in an affirmative action plan where you are analyzing the percentage of your workforce that are women, that are minorities, that are people with disabilities, and that are veterans. And, that's a significant task. And it's not, if you have a compliance department doing this and you're doing it yearly, it's actually not that hard at all. But if you haven't been doing it at all, then it's something that you really need to pay attention to. And then the second area is non-discrimination obligations. That's similar to the general obligation not to discriminate that exists under Title VII and the ADA, but it's a little more specific when you're talking about OFCCP and federal contractors because the agency expects you, as part of the affirmative action obligations I mentioned, to do a yearly assessment of your pay, promotions, and hiring in all your employment systems to make sure that there's not adverse impact that's happening against a protected class. And so you have affirmative obligations that touch on the non-discrimination requirement. And if you're found to be discriminating, that can lead to the loss of your federal contract. It can also lead to injunctive relief. So it's something that needs to be taken very seriously. One other thing I'd mention is a lot of times in the Title VII context, when you're talking about the EOC, you're often talking about assessing whether a particular employee has been discriminated against. OFCCP doesn't really look so much at particular employees, although it can. What OFCCP is looking at is your entire workforce. So they're looking at to see whether there's pay gaps among your doctors, for example, between men and women. And if those pay gaps cannot be explained by legitimate factors, the agency would make you correct that, not just for one person, but it could be for 100 or even 1,000 employees all at once. And that's why this is an area where there's a lot of potential liability. So those are the obligations. They're fairly extensive and they need to be taken seriously if you're federal or subcontractor.
Craig, a lot of the discussion is the prospective expansiveness of this enforcement action into the healthcare space and what you expect the regulators are going to be looking for. Are there actually already enforcement cases or actions that have produced compliance programs or other types of examples of responses from members of the healthcare industry?
Yes, there's actually quite a lot. You can actually go online and look at the agency's scheduling list. So you can look for yourself. And you can also look at the conciliation agreements, recent settlements that have been reached. A number of them are with healthcare companies, healthcare entities, hospitals, some of them university hospitals as well. And there are numerous recent conciliation agreements. And the other thing is I just remember from the whole issue with the TRICARE rule, the thinking at the agency was once we get that TRICARE rule done and it's clear what our jurisdiction is, the agency was going to focus more on healthcare because now the jurisdictional grounds are clear. So that means it gives the agency more authority, more clarity in who it can regulate and who it can't regulate. So I would expect that the amount of healthcare entities that are looked at will go up, are very likely to be a focus in a future scheduling methodology. So this is a good time to prepare. The Biden administration has made it very clear that affirmative action and pay equity compliance is something they're going to be very focused on. My successor as the OFCCP director, Jenny Yang, has said this numerous times in speeches, that she is very focused on pay equity. And I have to tell you, one of the areas where pay equity is really still a very present issue is in the healthcare field. It's an area where you have very significant pay gaps and pay disparities, which, is something that I think we're probably going to get into to talk about, because that you really do need to talk about that when you talk about hospitals.
So Craig, this is Sarah again. I was actually going to ask you about that, going back to what you had said a few moments ago about the pay equity, because certainly we know that in the healthcare field, there are lots of pay disparities, not just among specialties or specialists, but, between genders as well. And in addition, we know that certain specialties tend to attract different genders. So can you give us a little more description there as to sort of how the agency thinks about those types of disparities?
Definitely. So, in the medical field, and there's been a number of studies, but there's a fairly significant pay gap, for example, between men and women, around 1/3, like 33%, somewhere around there, 30 to 33%. It depends on the study you look at. And that's among, a general pay gap between men and women in the who are doctors, who are physicians.
That's huge. That's a huge pay gap.
It's one of the larger pay gaps. And the other interesting thing is OFCCP is in a lot of different fields, but the medical field is one where, particularly among doctors, where the salaries are much higher. So a 33% pay gap, 32% pay gap, that can translate to over $100,000 or even more in actual pay between a male physician and a female physician. That's a lot of potential liability. And it's also much easier for doctors to realize that they're being paid less when you have such a large disparity. And as the agency continues to focus more and more, and the Biden administration on pay gaps, pay disparities, and pay equity, I would think that you're going to see more and more employees, particularly female employees, be upset that they're being paid so substantially less than their male colleagues. And you're probably going to see more attention paid to this issue, more complaints made. So this is an area where it's important to be proactive. What's interesting is you might think, oh, well, maybe that's just in the surgical field, which is an area where physicians get paid a lot more. But no, actually, it's across the board. That's what's very interesting. That 32% pay gap, approximately 1/3 pay gap, is among specialists and also among primary care physicians. So it seems to be a general number. And then if you go into particular specialties, you still see pay gaps between men and women. So you mentioned that there is a pay gap between different types of specialties. So for example, one specialty that has a higher proportion of women, two specialties are OBGYN and pediatrics. Those are the two specialties with the highest proportion of women based on a recent study I looked at. And in those professions, those two professions are paid less than other specialist professions that are more predominantly male. So that's one area where there could be a disparity that the agency is likely to look at. The other areas within the professions themselves, you tend to see pay disparities between men and women. And here's the issue for hospitals. The fact that there's a pay gap between men and women, that alone does not necessarily mean that the hospital is discriminating. There may be a number of factors that play into that. One factor, for example, is that you're seeing a higher proportion of doctors are women now. A higher proportion of people graduating from medical school are women. Going back 20 years, it wasn't that way. It was much higher percentage of men. So among the most senior members of a particular specialty, it's a much higher proportion that are men. And those are the people that tend to get paid the most. So that may be part of the reason for the disparity, that among the more senior members or the highest paid members of a particular profession, they're more likely to be men because of that, what I just discussed. But you know what? That doesn't fully explain it. At least that's what OFCCP's view is. And also, one thing that the agency is doing is they're grouping these physicians together, including from different specialties when they run their regressions. And that's how the agency looks at this. They run regression analysis and see whether women are being paid so much less than men that it's more than 2 standard deviations on a normal distribution. And the agency often finds these sort of pay disparities when it groups lots of employees together. And one thing you should know is in Democratic administrations, they tend to be more likely to group large amounts of employees together because Democratic administrations tend to, I don't want to overgeneralize, but tend to be less deferential to the employer as to why they're paying people differently. So it tends to be a little more pro-worker than pro-employer, pro-employee than pro-employer. So what this means, though, and the reason I'm telling you this is hospitals need to be, when they're doing their pay equity analysis, first, they need to be doing them to begin with. And at least when I was at the agency, my understanding was a lot of companies don't do them, even though they're supposed to. But putting that aside, when they do them, they also have to be grouping. They can't just say, well, there's a 20% pay gap among our surgeons. And, it's explained because of years of experience. Well, understand that the agency may not, if the two doctors are basically doing the same surgeries and they're basically doing the same amount of work. And in fact, maybe some of the more junior physicians are doing more work. Maybe they're actually working more hours. The agency may not simply accept that because these particular male physicians are more experienced, they get more paid. They're going to look at the amount of work they do. What is the job description? And they may end up deciding not to control to the full extent for that. And that can lead a hospital to having substantial liability.
Let me ask you a quick question, because we've talked a lot about the hospital's responsibility. A lot of our clients I'm going to combine kind of a couple of questions going on about thinking proactively what we can help our clients with. First of all, some of them are in states where there is a corporate practice of medicine, and they are not directly employing physicians themselves. They have relationships with physician groups. They sometimes have financial interest or membership in those groups as well, but they are not the direct employer. And so first, I guess I'm asking is, do they need to be prepared and responsive to the agency's enforcement action? And if the answer to that is yes, how they and our other clients think about what it is that they have to do now. You started to talk a little bit about preparation, but I want to go back and make sure that we're teasing out who needs to be sensitive to this. And,
Sure.
And more importantly, to make sure that if people are not direct employers, but they still have responsibility, they don't let this go or let this out of their orbit and know how they are still responsible if they, in fact, are still on the hook.
Definitely. That's a great inquiry and great question. And it has a lot of parts to it because, initially, if you're a hospital and you're pretty certain you're a contractor or subcontractor, you may have independent contractors that work for you, but that are not employees. Those contractors are still federal subcontractors. So you need to make sure that in your contracts with them, you're putting in an equal opportunity clause and you're making it clear to that company you're contracting with or those doctors you're contracting with that they have an obligation with their medical offices, with their company to make sure that all of their employees have an affirmative action plan in place and that they're fully complying with the OFCCP obligations. So that's one thing that you should definitely do to make it clear that, look, that's an independent contractor. We're treating them like an independent contractor. We're telling them they have a flow down clause. We're giving them a clause that says they have to make sure their employees are protected. If you don't include that clause, or you're not really careful about maintaining that independent contractor relationship, it's very possible the agency will come in and say you're a joint employer and say, look, we need to make sure that these employees or contractors, what you would call them, these independent contractors who are doing the work of the government, and they're definitely subcontractors, we need to make sure that they're covered in an affirmative action plan. And they may try to put that burden on the hospital. So at the very least, make sure if they are independent contractors, you're including that equal opportunity clause and you're making it clear that they need to comply with these obligations. The other point is OFCCP's regulations about who are employees, they actually have some guidance on their website. And this is where it's good to talk to counsel because it's not necessarily the same test that is used, for example, for the wage and hour division or others. They're similar, but the agency has its own regulations about who is an employee for purposes of an AAP, and they have their own guidance. And it's very possible that they may take the view that those who you view as independent contractors, those doctors, nurses, that staff that you're contracting for, that they're your employees for purposes of this federal contract, and they may try to place the burden on you. So that's why it's very important to get legal advice in that area. So if it's okay, I wanted to, sort of conclude by talking a little bit about what healthcare entities should do. This is meant to be a positive podcast, not to say, oh my gosh, you have to do X and Y and Z and, no one's complying or things like that. A lot of companies are complying, but it's important to be proactive and understand that an ounce of prevention is worth a pound of cure. That's the old saying, and it's true, particularly in the OFCCP area. I've told you as the former director, I've given you an insight. The agency has established its jurisdiction in the healthcare area. It's an industry that's an extremely large industry, one of the largest in the federal contracting world. Healthcare is a huge part of the economy. There are large pay gaps that exist, which may or may not be explainable in full or in part for individual companies. And remember, a pay gap alone does not mean that you're going to be liable, but you have to be able to explain in a non-discriminatory, legitimate way why the male physicians are being paid more on average than the female physicians in that particular specialty. And let me tell you, that's getting harder and harder to explain as you're seeing more and more women physicians coming out of medical school, going into the specialties, working similar hours to their male counterparts. It's going to be harder and harder to explain that. And typically, the only way to explain that is, well, on average here, the women physicians either had less experience or they were working less hours. But that's becoming, I can just tell you from the regulator's standpoint, that's becoming a harder argument to make. So what I would suggest, and this is really when you have a 33% pay gap, 32% pay gap, it means that almost every healthcare company is going to have a gap. When it's an average gap like that, you need to go in there and you need to do a pay equity analysis, determine what the pay disparity is between male and female physicians, and you need to make pay adjustments so that the female physicians are paid similarly. If you are proactive and you do that every year, if you get audited, you're not going to have a problem at all. If you don't do that, you're looking at a lot of potential liability and an agency that might actually sue your entity, your company, in order to not only get compliance, but also to make you make all these pay adjustments and pay back pay. And that's one of the reasons why it's better to make pay adjustments now, because when the agency comes in and finds a problem, they're going to require you to do back pay. And that can be a lot of money. That can be tens of millions of dollars or more. So it's important to be proactive in this area. Plus, it's the right thing to do. It's important to pay men and women similarly. It's important to pay them equitably. That's something that companies agree with. And your HR, I know those listening believe that. That's part of the reason you're in this industry. You care about that. Well, this is your opportunity to do it. The Biden administration is going to be focused on this. This is the time to do it. Let's try to address that and end any pay disparities that are not explainable based on a legitimate fact.
Craig, this is Sarah again. In light of everything that you've shared with us today, can you give us a few specific takeaways, perhaps, as to what healthcare entities could be doing right now?
Yes, definitely. There's a lot that you should be doing right now. So first, prepare for affirmative action verification. OFCCP is doing something called the Affirmative Action Verification Initiative, where it's going to be requiring every federal contractor and subcontractor to verify compliance with the obligations I mentioned before, particularly the affirmative action ones. So it's very important to have affirmative action programs in place and be prepared to verify. And under the way that's been presented to the Office of Management and Budget, who has to approve these sort of initiatives, companies are going to be given basically 90 days to prepare their affirmative action programs and make that verification. That's not guaranteed to be 90 days, but that's the way it was presented. So if I were a healthcare entity, I would start on that now. If you don't have an affirmative action program in place, there's a legal obligation to have one. You know that the government's going to be asking you to state under oath, have someone that's high up in your organization verify that you have an affirmative action program. I would start on that now. I would talk to counsel about that. I would have those prepared with counsel and be prepared to verify. Second thing I would do is I would conduct a pay equity audit under attorney-client privilege. I mentioned that pay equity is a huge focus of OFCCP. The director has said that they're going to be focused on the healthcare industry. It's an area with a large pay gap. So be proactive, conduct a pay equity audit, but it's very important that you do that under attorney-client privilege. The reason why is because you may find pay gaps. As I mentioned, there's a fairly large pay gap in the healthcare industry. So you are likely to find pay gaps based on both race and gender, and also the intersection of race and gender. Pay gaps, one of the largest pay gaps relates to women of color, particularly Black women and Hispanic women. That's in the medical field as well. So you need to determine what to do with those pay gaps. One, are they pay gaps caused by discrimination, or are there other factors that are contributing to that pay gap? Two, what is the amount that's caused by discrimination or disparate impact? It could be disparate treatment, disparate impact, whatever it may be. You have this disparity. You know about it. It's underprivileged. You need the advice of counsel as to how to address that. Do you make a pay adjustment to everyone? Do you adjust it based on the amount of the gap per employee? You need to get that legal advice from counsel, because the problem is if you have a pay gap and it's not all caused by discrimination, it's just an average gap, and you go in there and you don't do it under privilege, first of all, that could become public during an OFCCP audit, and it could be used against you. Even if it's not caused by discrimination, that could be used against you. Oh, you knew about this pay gap. Why didn't you act? Why didn't you take action? Two, if you just find a 30% pay gap and say, well, we're going to pay all women 30% more, well, what you're going to do is you're going to discriminate against men in doing that, because there will be, in different specialties and in different job groups, not all of them will be at 30%. Some of them will be at 10%. Some of them there may be pay gaps against men. You need to do a more thorough, comprehensive analysis to see what are the pay gaps for each of the specialties, each of your job groups, and then address those. And only address the parts that are caused by discrimination, because that's what you're authorized to do under Title VII and under the executive order. Otherwise, you're making pay decisions based on gender or race, and that's illegal. You're not allowed to do that unless you've identified an actionable pay disparity to correct. And then the last thing you should do is have a proactive diversity and inclusion initiative and make sure that that initiative is compliant with Title VII. Those initiatives should be inclusive. They should have things like employee resource groups. They should have trainings on inclusion and diversity and being open-minded and making sure not to stereotype or certainly not to discriminate against other employees, but also, talk about unconscious bias training and things like that. Things might not always be intentional, but it may still cause an impact as to another employee. So you want to teach people to treat each other with respect and in an inclusive way. And this is something that I talked a lot about in the area of disability. You also want to make sure that people are giving reasonable accommodations to people with disabilities, that it's a neurodiverse workforce and people are respectful of others, including on mental health issues, cognitive disabilities, psychiatric disabilities, in addition to physical ones. All of those should be part of a compliance program, and training people to be cognizant of those and to be inclusive and kind and respectful. So that's something that I would do as well. I would do this all together as a comprehensive program. And if you do that, when OFCCP comes knocking, you're going to get an audit closure and go on your way.
Craig, you've given everybody so much to think about, so much substance, so much good information. I thank you very much for being here with us today and sharing with us your time and your expertise. Thank you.
Thanks again for listening to this episode of Triage, recorded in collaboration with WorkingWise. New episodes are available for download through Apple Podcasts, Google Podcasts, and Spotify. By subscribing to Triage, you will receive timely notifications for each new episode. Also, if you have any topics you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.